Okay, so the last time we finished first part of chapter 18, we talked about the hormones, different types of hormones, and we stopped at the steroid hormones. And the most important point from the beginning of the chapter until now is the nature, the chemical nature of the hormones. The importance of the chemical nature is the effect of the hormone. Is the hormone going to exert the effect on the cell membrane if it is not lipid soluble, or the hormone is going to cross the cell membrane, enter the cell, and do the action whether inside the cytoplasm or in the nucleus, and more often actually in the nucleus. So steroid hormones being one of these hormones that are lipid soluble, they can easily cross the cell membrane that consists of a bilayer or two layers of phospholipid. So anything that's lipid or lipid soluble will be able to cross the cell membrane and enter the cell. So steroid hormones are going to enter the cell, cross the cell membrane, enter the cell, and they will bind to receptors whether in the cytoplasm or in the nucleus, so they can actually affect the genes, whether activating or inactivating. So this is showing you the steroids entering, and then they can easily cross the cell membrane, and they can work either on receptors in the cytoplasm or within the nucleus. So they are going to being able to work whether in the cytoplasm, like mitochondria, or in the nucleus. So they can actually alter the rate of DNA transcription. They can affect actually the transcription of DNA in the nucleus. So what's the importance of that? The importance is they are going to change the pattern of protein synthesis. If they can affect the DNA transcription, so the DNA will be transcribed to make RNA, and RNA will direct the protein synthesis. So this is how the steroid hormones will end up changing the pattern of the protein synthesis. So the overall will be affecting the metabolic activity of the cell. Endocrine reflex. This is a control, one of the ways to control the endocrine system. And basically the endocrine reflex is just like the neural reflex that we covered before in Bio234, which is a reflex that starts with stimulus receptor, and then it will go to the control center and it will reflect as a change. So it is kind of similar to the neural reflex, except it is slow. The neural reflex was fast, and most likely the endocrine reflexes are controlled by negative feedback that we talked about before. The endocrine reflex triggers what trigger the endocrine reflex? Either something composition changed in the extracellular fluid, and this is called humoral, or hormonal stimuli, hormones that arrived or removed, a specific hormone that arrived or removed that can trigger the endocrine reflex, or neural stimulus. Actually, the nervous system have some effects, or can have effects integrating with the endocrine system, which is called the neuroglandular junction. Neuro means the nervous system, and glandular is the endocrine system. So the nerves can actually send stimuli to control the endocrine system. The endocrine reflex can be simple or can be complex. Simple means involving one hormone only, and this is like the control hormone secretion, like by the heart, pancreas, parathyroid, and digestive system, while the complex endocrine reflex will involve two or more hormones, so one or more intermediary steps. There are steps in the middle. So if it is two hormones, there will be one step. If it's three hormones, there will be two intermediate steps, and so on. Now, starting from this part, this is the most important part in the endocrine system, and the hypothalamus is the first thing that we will talk about. And hypothalamus is considered the president or the CEO of the endocrine system. Just like when we did the nervous system, we said that the cerebral cortex was the highest level of management of the nervous system. The hypothalamus is the same for the endocrine system. So it is the highest or the top management for the endocrine system. The hypothalamus will actually have three different effects or three different jobs to do. Being the president or the CEO or the highest control of the endocrine system, it is going to secrete regulatory hormones. And these regulatory hormones, regulatory means it can be stimulatory and it can be inhibitory. So these regulatory hormones, the hypothalamus will synthesize them, and it will send it via the infundibulum going to the pituitary gland. This is the pituitary gland. Which part of the pituitary gland? The anterior pituitary, which is also called the adenohypophysis. So the other name for the anterior pituitary, pituitary in general means hypophysis. Anterior pituitary, adenohypophysis. Posterior pituitary, on the other hand, is called the neurohypophysis. So anterior and posterior pituitary or adenohypophysis and neurohypophysis. The regulatory hormones will go from the hypothalamus to the anterior pituitary, and when they go to the pituitary gland will read the instructions, and we can consider the pituitary gland like the vice president or something that are going to send other orders or other regulatory hormones to all other endocrine glands. And it's not going to take the same regulatory hormones or the same orders that came to it from the hypothalamus. It's not going to send it as is. No, actually it will receive the orders of the regulatory hormones, and it is going to understand it, process it, and then it's going to make its own regulatory messages or messengers or hormones that will go to all the other endocrine glands. So the point here is the regulatory hormones that start from the hypothalamus will end at the pituitary gland. That's it. It's not going anywhere else. The pituitary gland will develop its own, which is the other line here, its own hormones that will travel and go to different endocrine glands. This is one job. So this is the main control job. Beside that, the hypothalamus will say, okay, I'm not only going to be controlling and only being like the big boss or the CEO or the president of the endocrine system. I can actually do something in my spare time. I'm going to help a little bit, produce a couple of hormones to help the endocrine system. So not only controlling other glands, but I'm also going to share. And they are going to produce ADH and oxytocin. And we will talk a little bit about ADH and oxytocin later on. But these hormones are secreted from specific nuclei that we will need to learn, we will need to know, we will see it later on. But it goes from the hypothalamus, so the hypothalamus make it, and it will travel down the infundibulum going to the posterior pituitary, which is the neurohypophysis. The neurohypophysis or the posterior pituitary is going to store it, and then when needed, it will leave the posterior pituitary and go to exert the action on different organs. Like ADH will go to the kidney, oxytocin will go to the breast or the mammary gland, and to the uterus too if needed, and it's a contractor. It contracts the smooth muscles. The third function of the hypothalamus, beside control, beside secreting those two hormones, so it being an endocrine organ, it's helping also. Number 3, it controls the sympathetic output of the adrenal medulla. So the adrenal medulla is part of the sympathetic system. It is a modified ganglia that secrete epinephrine and norepinephrine, and this is under the control of the hypothalamus. So this is the only exception. This it's sympathetic, but it's not controlled by the nervous system. This part of the sympathetic is controlled by hypothalamus, and the hypothalamus also coordinates and communicate with the nervous system. So it is kind of a link between the nervous system and the endocrine system. So regulatory hormones that we are talking about and act as an endocrine organ: ADH, which is antidiuretic hormone, and oxytocin, and autonomic centers, as we just mentioned. And there is another reflex that's called the neuroendocrine reflex. We said neuroreflex, the neuroreflex that we talked about in Bio234, and we talked about the endocrine reflex, and there are some reflexes that have the two components. Pathways include both components, neural and endocrine components. The secretions of the hormones can go in different quantities and different ways of secretion. It can be secreted as pulses, like sudden burst. You secrete good amount and then stop. You secrete another amount and stop. This is called pulses, which is interrupted secretion, versus it can also secrete a continuous secretion. Basically, the hypothalamus and pituitary are going to work by the sudden burst, which is the pulses, and most of the other hormones, other endocrine glands, will work by continuous secretion. We said pulse. How many pulses per minute, for example, or per hour? It depends on the target organ. The pituitary gland is located in the cella turcica. If you still remember the inside of the skull, we had this cella turcica, or the Turkish saddle, or the saddle horse. This is the area that houses the pituitary gland, which is also called the hypophysis. So it is located in there, and there is a diaphragm that cover the upper part, so covering superior to the pituitary gland. So the pituitary gland is locked in, so it doesn't move here or there. So the secretions will not be affected if it started to move. And as we know, the pituitary gland is connected to the hypothalamus through middle part that's called the infundibulum. The pituitary gland is the pituitary gland, and the pituitary gland itself consists of three parts. This part right here, and the part is called pars. So there is the anterior pituitary itself, or the anterior lobe of the pituitary gland, consists of pars distalis, pars tubularis, which is this part in the back here, pars distalis, and pars intermedius, which is in between. And then we have the posterior lobe, and there is a median eminence up toward the hypothalamus. So the other name for the pituitary gland is hypophysis. Adenohypophysis is anterior. Neurohypophysis is the posterior lobe of the pituitary gland. And again, it's located in the cella turcica and connected by the infundibulum to the hypothalamus. Diaphragma Sellae is a diaphragm I was talking about that locks the pituitary gland in position within the cella turcica inside the cranial cavity, so that it doesn't move. There are different peptide hormones that are released, 9 peptide hormones released from the pituitary gland, that we will talk about it in details. And when we say it's a peptide hormone, it means it is amino acids that are attached together by a peptide bond. So being an amino acid, obviously it's not lipid soluble, so it will not be able to cross the membrane like the lipid soluble hormones was able to. So this is not going to happen. So what's going to happen is these hormones, being peptide hormones, they will go to the membrane only. They cannot enter. They will interact or bind to receptors on the membrane, and then the action will be mediated through the second messenger, which is in this case is a cyclic AMP. But as we mentioned before, it can be something else. It can be like cyclic GMP or calcium, like other second messengers. I'm talking generally speaking about the second messenger, but in this case it's a cyclic AMP. So there is pars distalis, pars intermedius, and pars stipularis. These are the three parts of the adenohypophysis, which is the anterior lobe of the pituitary gland. There is also median eminence, which is a swelling near the infundibulum, and this is where the hypothalamic neurons will release the regulatory factors. It's released, so the hypothalamus make the regulatory factors and send it to the median eminence, which is this swelling, and it goes to the interstitial fluid, enter through the fenestrated capillaries until it goes to the pituitary gland. So here's the median eminence and showing the fenestrated capillaries where the regulatory hormones can travel through these capillaries and go to the pituitary gland. Portal vessels, these are blood vessels that link two capillary networks, and it's called altogether it's called the portal system. Hypophyseal portal system, this is the system that communicates or the regulatory factors until they go to the target cells and go to circulation to the target cell. The hypothalamic regulatory hormones, we said regulatory means regulation, and regulation can be stimulation or inhibition. The stimulatory ones are called releasing hormones, and the inhibitory are called inhibiting hormones. So there are two types of hormones that are secreted in the hypothalamus. Some of them are releasing, the other ones are inhibiting. This table is very important, showing us the different types of hormones. So these are the releasing hormones: TRH, CRH, GnRH. TRH is thyrotropin releasing hormone. Thyrotropin, thyro means thyroid, tropin means trophic, and trophic means stimulate or stimulate the growth of. So trophic or tropin means stimulate growth of or stimulate the function of. So this is thyrotropin releasing hormone. So this is a hormone that stimulates the release of thyrotropin. What's the thyrotropin? Thyrotropin is a hormone that's released from the pituitary gland that's tropic or trophic to the thyroid gland. So TRH is released from the hypothalamus, goes to the pituitary gland, the anterior pituitary. The anterior pituitary will take that order, which is a TRH, will understand it, process it, and it will make its own order, which is the TSH. The TSH is the one that's actually going to go to the thyroid glands. And when it goes to the thyroid gland, it's called the TSH, meaning thyroid stimulating hormone, meaning the hormone that stimulates the thyroid gland to secrete thyroid hormones. So this will be the end result, thyroid hormones. The second releasing hormone from the hypothalamus is CRH, which is corticotropin releasing hormone. So this is a hormone that stimulates the release of corticotropin. What's a corticotropin? ACTH, that's released from the hypothalamus. So each name from the pituitary secretions has two names actually. Each hormone have two names. So CRH released from the hypothalamus, it will go to the pituitary gland. That's it. The pituitary gland will understand why CRH is coming, and it will respond by producing ACTH, which is adrenocorticotrophic hormone, and always try to cut the word into pieces to understand it, to make it easier to understand. So ACTH, adrenocorticotrophic hormone. Adrenocortico means the adrenal cortex. Trophic hormone or tropic hormone, this is the hormone that stimulates the function of tropic. So trophic hormone, it's a trophic hormone for the adrenal cortex. We know that the adrenal gland, ad means above, supra means above, so ad and supra is the same. So the gland that's above the kidney, adrenal, above the kidney, or suprarenal, above the kidney too. This gland there is a core inside the gland, and there is a cortex or a cover outside. This will work on the cover to secrete glucocorticoids, which is the well-known cortisone, for example. The third releasing hormone that's released from the hypothalamus is GnRH, which is gonadotropin releasing hormone, gonadotropin releasing hormone. So this is a hormone that will go to the pituitary gland, and the pituitary gland will respond by secreting the gonadotropins. What are the gonadotropins? This is 2 of them, not just one, like the other ones. This is FSH and LH. FSH is follicle-stimulating hormone, and LH is luteinizing hormone. FSH coming from follicle-stimulating hormone. Follicle means these are the follicles in the ovary in females, which houses the ova, and then it will release it. LH is luteinizing hormone, and luteinizing means it causes luteinization. What's a luteinization? Luteinization is the formation of corpus luteum. So this is in females, but it does have some effects in males too, because both of them are secreted in male and females, and they have different functions. FSH, that's produced from the pituitary gland in response to gonadotropin releasing hormone coming from the hypothalamus. So the pituitary will respond by secreting FSH, and FSH is follicle-stimulating hormone. It will go to the testes in males and ovaries in females. Testes in males, the testes will respond by secreting inhibin, and inhibin is inhibitory hormone. In females, FSH go to the ovaries, and the ovaries will also respond by secreting inhibin, but it will plus estrogen. LH, on the other hand, will go to the ovaries in females and will stimulate the ovaries to secrete progestin and estrogens, female hormones. Testes so LH on the testes will secrete androgen. So these are the secretions. We start from releasing hormones from the hypothalamus, goes to the pituitary gland. The pituitary gland will release its tropic. Anytime you see tropic or trophic, means stimulatory, stimulate the growth of. Trophic to something. Corticotropic means tropic to the cortex, meaning stimulate the growth and function of the cortex. The next part of the hypothalamic regulatory hormones are 2 hormones, and those 2 hormones are different than the other hormones because the hypothalamus can secrete the hormone and the opposing hormone too, which is the stimulatory and inhibitory hormones. Both of them can be released depending on the needs. So prolactin releasing hormone or releasing factor, this is actually a factor. So prolactin releasing factor is a factor that's released from the hypothalamus and go to the anterior pituitary, and the anterior pituitary will respond by producing prolactin. So prolactin releasing factor is a factor that go to the anterior pituitary to ask the anterior pituitary to release the prolactin. Prolactin, pro means before or towards, so prolactin toward lactation, prolactation. So this is going to stimulate the mammary gland to make milk for the baby, for breastfeeding. But on the other hand, it can also secrete PIH, which is prolactin inhibiting hormone. But first it stimulates prolactin releasing hormone that goes to the anterior pituitary. The anterior pituitary will release prolactin. Prolactin go to the mammary gland, releasing milk. When the prolactin start to accumulate, it will go to the hypothalamus and say to the hypothalamus, I'm accumulating. There's a lot of prolactin here, so stop secreting prolactin, releasing hormone or releasing factor, and start to release actually the opposite or the opposing factor, which is the prolactin inhibiting hormone that goes to the anterior pituitary and tell the anterior pituitary do not produce any more prolactin. and the cycle will goes on and on as needed. On the other hand, the hypothalamus will also secrete growth hormone releasing hormone that goes to the anterior pituitary, and the anterior pituitary will respond by secreting growth hormone. If growth hormone will go to the liver, and the liver will secrete something else, another hormone that's called somatomedin. And again, when you read something, try to cut the word into different pieces so it will make it easier for you to understand. It's called somatomedin. Soma means body, medin means mediation. So somatomedin is the hormone that mediates the growth hormone effect on the body. Somatomedin, mediation on the soma or on the body. So it's a hormone that mediates the action of growth hormone on the body or on the soma. So when somatomedin itself go to the different parts of the body, skeletal muscles, bone, cartilage, or different tissues, it works on the entire body, and when it starts to accumulate, it will go back and go to the hypothalamus and tell the hypothalamus just the same thing as we said with prolactin, which is, hypothalamus, you need to stop producing growth hormone releasing hormone because growth hormone and me, we are accumulating, so you need to stop. And actually, you need to start producing the opposing hormone, which is growth hormone inhibiting hormone. So, by doing this, the signal will go, or the inhibiting factor will go to the anterior pituitary, telling the anterior pituitary, do not produce any more growth hormone. So growth hormone will not go to the liver, will not form somatomedin. So you're down regulating the somatomedin, and this is called the negative feedback, which is the mechanism that controls the vast majority of the endocrine glands. So releasing hormone, we talked about this, and inhibiting hormones. We covered the anterior pituitary, the secretions already in the table. Again, for each one of these stimulating hormones, there is another name that's called tropin, and tropin is the same thing as stimulating. So thyrotropin means tropin to the thyro, means tropin to the thyroid gland, means stimulating the thyroid gland, which is basically the same thing as thyroid stimulating hormone. ACTH, adenocorticotropic hormone, adenocorticotropic. It's tropic to the adenocortical. What's the adenocortical? Adrenocortical means the adrenal cortex, the cortex of the adrenal gland, the cover or the outer layer of the adrenal gland. So it is trophic to the adrenal cortex, the adrenal cortex, the adrenal cortex. So it's called again corticotropin, and it will go to the adrenal cortex, and the adrenal cortex will respond by secreting glucocorticoids. Gonadotropins or gonadotropins. Gonadotropins. Tropins to the gonad. Stimulate the gonads. The gonads, the word gonad is an umbrella that means reproductive organs. The reproductive organs are testes in male and ovaries in female. So gonadotropins, they are tropin to the gonads, so they go to the testes and ovaries, which are the gonads, and being trophic to them, meaning stimulate them. These are the FSH and LH that we talked about before. The FH is called folitropin, means tropin to the follicle, which is the ovarian follicle, the follicles in the ovaries that will produce the ova and produce also some secretions. So FSH go to the ovaries, and the ovaries secrete estrogen. It goes to, in males, on the other hand, FSH goes to the sustentacular cells. And you need to remember all these cells. So about the hormones, you need to remember the name of each hormone, you need to remember the function of each hormone, and where is it secreted exactly, from which cell, and the regulation of the hormones. This is the most important of this chapter. So FSH go to the subtenticular cells that will promote the maturation of sperms. It also the production is inhibited by inhibin. So FSH inhibit the FSH, which is secreted also from the testes. LH on the other hand is called luteinizing, and it will cause in females it will cause ovulation and progestin. In males it will cause the production of androgen. So androgen males, progestin, and ovulation in females. Of course, both of them are regulated by gonadotropin releasing hormone that's produced in the hypothalamus, as we mentioned before. Prolactin, mammotropin, this is the other name that we need to know, and we talked about it already. It's prolactin, meaning prolactation, meaning it stimulates the mammary gland to make milk, which is lact. Lact means milk. So it's mammotropin and stimulated by prolactin stimulating hormone or factor, and inhibited by prolactin inhibiting hormone. Growth hormone, we talked about it already. There is growth hormone releasing hormone, growth hormone inhibiting hormone. Those two come as needed from the hypothalamus and go to the pituitary gland. So remember that we mentioned that in the hypothalamus, beside the other jobs, it also helps as an endocrine organ by secreting ADH and oxytocin. So the pituitary gland, on the other hand, will do the same thing. It will secrete prolactin and growth hormone. So pituitary is sharing with two, the hypothalamus is sharing with two, and all other glands will secrete the rest of the hormones that we will talk about. There's one more stimulating hormone that's called the MSH, or melanocyte-stimulating hormone. And melanocytes, melano means melanin, cyte means cells. So this is the hormone that stimulates the melanin producing cells, which is in the skin. The other name is melanotropin. So it will stimulate the melanocytes to produce melanin in adults. And so what stimulates the melanocyte stimulating hormone? Dopamine will inhibit the secretion of melanocyte stimulating hormone. So each hormone, we're learning the function, what stimulated and what inhibited. The melanocyte stimulating hormone that's secreted from pars intermedia of the pituitary gland. So this is the third one that's secreted from the pituitary gland. In fetus and early childhood and pregnancy, it has some different functions, but this is something additional beside the regular functions in adult, which is stimulation of the melanocytes to produce melanin. In fetus, it promotes the fetal development. It promotes the development in early childhood. It has some effects on pregnancy, and in certain diseases it has some. It can have some irregularities, but generally speaking, the main function in adult is the most important thing, which is stimulating the melanocytes to produce melanin, which is the black-brown pigment that make the skin darker. The posterior lobe of the pituitary gland, on the other hand, which is called neurohypophysis, it contains the unmyelinated axons of the hypothalamic neurons. So the neurons from the hypothalamus, the unmyelinated axons of these neurons, leave the hypothalamus and go end at the neurohypophysis to store the oxytocin and ADH that was produced by the hypothalamus, store it in the posterior lobe of the pituitary gland, which is the neurohypophysis. Actually, we need to know exactly which nuclei make it, which nuclei in the hypothalamus. Supraoptic nuclei will make ADH, paraventricular nuclei will make the oxytocin. So these are the nuclei, meaning the supraoptic nucleus or nuclei will make the ADH, and the ADH will travel through the axons of these nuclei from the hypothalamus and go to the pituitary gland. Paraventricular nuclei, on the other hand, they will secrete oxytocin from these nuclei. Oxytocin will leave the nuclei, travel along the axons of the hypothalamic neurons, and it will end up being stored in the posterior lobe of the pituitary gland, and when needed it will be released and do the action as mentioned before. What's the ADH? Just same rule, cut it into pieces. The antidiuretic hormone, the hormone that's against diuresis. What's diuresis? Diuresis means making urine, means losing water or getting rid of water in urine. Anytime you see uresis or diuresis, know that we're talking about more water being lost in the urine. Uresis, increasing the amount of urine, or increasing the amount of urine by adding or getting rid of more water in the urine. The antidiuretic hormone, on the other hand, it is against that, against losing water. So it actually take the water back from the kidney. The entire blood circulate through the kidney. The water will be filtered out, and then the ADH will take the water back or stimulate the water to be reabsorbed and go back, leave the kidney, go back to the blood. So when you increase the amount of water that's going back to the blood, so you're increasing the blood volume, and when the blood volume increase, the blood pressure will be elevated. Just by the way, as we discussed before, what increase the blood pressure? What increase the blood pressure is, number one, increase the blood volume, as we just mentioned right now. Vasoconstriction will decrease the diameter, so will cause more blood friction. The blood will make more friction with the wall of the constricted vessels. If the walls are dilated, there will be less friction of the blood with the blood vessels, so the blood pressure will go down. So friction is the pressure. So what's the blood pressure? It's the friction of the blood in the wall of the blood vessels. So when you have less amount of blood, there will be less friction of the blood in the walls of the blood vessels, and the blood pressure will go down. If the volume increase, there will be more pressure or more friction of the blood with the blood vessels, and then the blood pressure will go up. This is one thing. The other thing is, as mentioned, the diameter. When the diameter decrease, which is vasoconstriction, the blood will have more friction with the wall of the blood vessels, so that will increase the blood pressure, versus if the blood vessels dilate or increase diameter, the blood will have less friction with the wall of the vessels, so that will decrease the friction of the blood with the wall of the blood vessels, which means decrease blood pressure. Number three, the viscosity of the blood. If the blood is more viscous, it will produce more blood pressure. If it is less viscous, viscous means thicker, so if it is less viscous, the blood pressure will decrease, because if it is more viscous, there will be more friction with the wall of the blood vessels, and we will talk about that later. And we usually hear about people drink a lot of alcohol and they go to the bathroom a lot. They woke up in the middle of the night 3, 4, 5 times and go to the bathroom, and the reason why is alcohol. When you drink alcohol, the alcohol will inhibit the ADH, so you will not be able to reabsorb enough water, so you lose a lot of water. So this is called diuresis, which is the opposite of antidiuresis, and you're losing a lot of water in the urine, so you have larger volume of urine, so you go to the bathroom more frequently. Now oxytocin. Oxytocin is the second hormone. So we talked about ADH. Oxytocin, the second hormone that's released or it's synthesized in the hypothalamus, in the nuclei of the hypothalamus, and it travels along the axons and go to the posterior pituitary of the neurohypophysis to be stored there. And when it goes to the mammary gland, for example, oxytocin, generally speaking, is a stimulant of the contractile muscles, smooth muscles. So there are smooth muscles in the mammary gland, which are the muscles that surround the glands itself. So when it contracts, it will push the milk out, and also it stimulates the smooth muscles of the uterus. So if you ever see a lady during delivery and they have that solution hanging and the cannula is inserted, and sometimes they inject, like an injection, they inject something in the solution, and that to accelerate or to augment the uterine contractions. If like the mom is exhausted or the uterine contraction is weaker and they cannot expel or push out the baby, so they can use oxytocin that goes in the solution, go to the blood of the mom, go to the uterus, and contract the muscles, pushing the baby out. On the other hand, when it contracts the mammary glands, the milk will be ejected, and this is a reflex. This is an example of the neuroendocrine reflex. When the baby starts to suckle from the breast, suckling the nipple, the nervous system, which is a neuro part, will go and cause a release of oxytocin, and oxytocin will return back and go contract the muscles around the mammary glands, and these muscles will contract, pushing the milk out. And when the baby stops suckling, the oxytocin will not come and the milk will not be ejected out, so that the baby can drink it. This is a summary. It's good to know. It's summarizing what we talked about. So it's important. It's good to know. But I'm not going to repeat it again. It's just putting everything together. Same thing here. Now the thyroid gland. Now the thyroid gland. The thyroid gland, the most important thing to remember about the thyroid gland is that it stimulates the overall metabolism of the body. So if you understand that it increases the metabolism, and metabolism is all reactions happening in the body, so it stimulates the overall metabolism. So if you understand that, you will understand that the tissues will use more oxygen, the heart rate will increase, the contraction will increase, the blood pressure will increase, sympathetic nervous system will be stimulated more, respiration more, blood cells more, heat will be more, and so on. And that's why people who are having hyperthyroidism, like goiter or something, if they have the thyroid gland that's hyperfunctional, they always feel that the temperature is really high, so they feel hot, and everybody else feel at the same time. If everybody else is feeling fine and they don't think it is hot, and they think it is really hot. On the other hand, the people who have hypofunction or hypothyroidism, those are people who do not secrete enough thyroid hormone, and they feel really cold, like they are shivering while the room temperature is just fine. Everybody else is feeling okay, while those people will feel that it's cold. Again, it all go back to metabolism, increased metabolism that reflect on everything else. Parathyroid gland secrete parathyroid hormone, which is known as parathormone, or the parathyroid hormone in general, and this is number one friend of calcium. It increases the blood calcium level. The normal blood calcium level is from 8.5 to 11 milligram per deciliter, and if it goes down, let's say 7 or 6 or 5, the parathyroid gland will sense it, will feel it, and will start to produce the parathyroid hormone. And the parathyroid hormone will work on the bone, it will work on the urine, the kidney, to increase the calcium level. It's going to go to the kidney to reabsorb calcium, take it back to increase the calcium in the blood. It will also go to the bone to take calcium from bone, and it will also indirectly affect the absorption of calcium to increase it by all these three actions, it will end up increasing the calcium back to normal, and that's it. You don't want it to bring it back. You want to bring it back up to normal, not above normal. On the other hand, if the calcium level is above normal, so it should be 8.5 to 11. If it is 12, 13, 15, there is another hormone that's secreted from the thyroid gland. And we talked about thyroid gland. We said thyroxine, which is T4, and triiodothyronine, which is T3. These are the secretions of the thyroid gland. These are the well-known secretions, but there is one more hormone, which is calcitonin. And calcitonin is the enemy of calcium, meaning it will try to decrease the calcium level in the blood if it increased. So calcium level goes up, calcitonin will bring it back to normal. Calcium level goes down, parathyroid hormone will bring it back up to normal. So thyroid and parathyroid in summary, and we actually need to know which cells secrete which hormone. So thyroid gland have two types of cells. Follicular cells secrete T3 and T4. T3 is triiodothyronine and T4 is thyroxine. C cells, on the other hand, will secrete calcitonin, and actually the C coming from the calcitonin. The C is the first letter of calcitonin, so you don't remember it, you don't forget it. So C for calcitonin. Calcitonin is secreted from C cells of the thyroid gland. The parathyroid chief cells of the thyroid gland will secrete parathyroid hormone. Adrenal gland, again, adrenal means above renal, above the kidney, and the adrenal gland is a gland that's located above the kidney, which is the same as suprarenal, and it consists of core, an inside core, and outside cover. The core inside is called the medulla. This is the adrenal medulla or the adrenal medulla, and the outside is called the adrenal cortex, and each one of those will secrete different hormones, of course, as a response to the ACTH that's coming from the pituitary gland. So the cortex have three different zones: zona glomerulosa, zona fasciculata, and zona reticularis. Zona glomerulosa will secrete mineralocorticoid, which is basically aldosterone. Zona fasciculata will secrete the glucocorticoids in general, like cortisol, hydrocortisone, corticosterone. These are the three glucocorticoids that are secreted from the adrenal cortex, specifically from zona fasciculata. Zona means zone, and fasciculata, this is the name of the zone, so each zone will secrete a specific hormone. Zona reticularis will secrete androgen. We know that testes secrete androgen, but testis is the main source, the actual source. Zona reticularis will secrete androgen during childhood or during infancy only, and it's not important in adult men. So in adults, the androgen is actually coming from the testes. The part that come from the zona reticularis of the adrenal cortex play some role during childhood. The medulla, on the other hand, will produce epinephrine and norepinephrine, and those two hormones are sympathetic hormones. If you remember the sympathetic and parasympathetic from 233, this is sympathetic, which is fight, fright, flight. If you are frightened, if you are fighting, remember what happened to you. The cardiac activity increase, heart rate increase, blood pressure increase, you feel warm, heat, sweating, blood glucose increase, glycogen breakdown increase, energy increase, and so on. So you activate basically all activities that are related or that will enable you to fight. So this is for the adrenal medulla or the adrenal medulla, which is the core part of the adrenal gland. Pancreas. The pancreas anatomically consists of body, head, neck, body, tail. Head, which is the part that's close to the duodenum, which is the first part of the small intestine. We will discuss the more about the anatomy of the pancreas and duodenum and other things in the digestive system, which is next part. But for now, what we need to know about the pancreas is the hormones that are released from the pancreas. So there are two types of glands in the pancreas. The pancreas have some lobules which contain which are the glands that secrete enzymes, and there are actually some islets, and islets means island, which is called the islet of Langerhans. The name came from Langerhans, the scientist, so they called the islet by his name. And islet means island, so these are small pieces, small islands in the middle of the pancreas. So the main thing is the pancreatic acini, which secrete the different enzymes. But our focus now, since we're talking about the endocrine system, is about the hormones. So the hormones are secreted from the islet, the pancreatic islet or islet of Langerhans. Two hormones are important: insulin and glucagon. We all know insulin, and insulin obviously decrease or lower down the amount of glucose in the blood. The normal fasting glucose level is 70 to 100 or 170 to 110, which is very close to the normal blood pressure if you forgot it. So blood sugar or blood glucose is kind of close to the blood pressure. Blood pressure should be 110 over 70 or 120 over 80. So this is 110, close to 110 over 70, so you can remember it, but it's 70 to 110. This is a normal. If the glucose goes down, so instead of being in between 70 and 110, which is the normal fasting level, if it's like 50 or 60 or something, glucagon will be secreted from the pancreas, and it will increase the sugar level or the glucose level back to normal. On the other hand, if it increases, so instead of being from 70 to 110, it goes to 130, 150, and so on, insulin will be secreted in this case, and it will lower down the glucose level back to normal. So even though both insulin and glucagon are produced from the pancreas, both of them are produced from the islet, pancreatic islet or islet of Langerhans, but they do opposite action depending on the need, which basically depend on the amount, the level of the glucose. If it goes up, insulin take the upper hand and bring it back down to normal. If it goes down, glucagon take the upper hand and bring it up, back up to normal. So alpha cells secrete glucagon. Alpha cells of the islet produce glucagon, which increase the blood sugar, blood glucose in the blood. Beta cells produce insulin, which decrease or lower down the glucose level in the blood. And we also need to know how it does the insulin decrease the glucose level in the blood. It actually decreases it by pushing the glucose, moving the glucose from the blood to the inside of the cell. So when you take it from the blood, push it inside of the cell, it will leave the blood, so the level in the blood will decrease. This is how the insulin specifically decrease or lower down the level of glucose in the blood by pushing it inside the cells. Delta cells will produce growth hormone, inhibiting hormone, and F cells will produce PP. This is less important. It's more important to remember alpha cells produce glucagon, which increase glucose level in the blood. Beta cells produce insulin, which lower down the glucose in the blood. There are other hormones that are released from different organs, like from the intestine. You have different hormones that will be covered more when we do the digestive system, which is basically secretin, gastrin, cholecystokinin. These are just examples, and we will talk about it. But the point is, the intestine does produce some hormones. The kidney produce erythropoietin and calcitriol, and this is important to remember. Erythropoietin, erythro means red, and it's referring to the red cells. Poietin, again, we mentioned it before, poietin or poiesis means making or manufacturing. So erythropoietin is the hormone that go to the bone marrow to stimulate the synthesis of red blood cells. And the other hormone that's released from the kidney is calcitriol, and the calcitriol will have some effect on the calcium, increasing the calcium absorption. From the heart, even though the heart is is part of the cardiovascular system, so the function is to pump the blood, but there is an additional endocrine function, which is the releasing of natriuretic peptides. And natriuretic means natriuresis. Na, which is sodium, uresis means urine. So this is the hormone that will push sodium in the urine. So you decrease sodium level in the blood, and every time always remember that sodium is always followed by chloride or chlorine. So sodium and chloride together, that will make the sodium chloride, which is the table salt. And when you get rid of sodium in the urine, chloride will automatically follow sodium. So now we have sodium chloride, which is salt. Water will always follow salt. So it goes without saying automatically. Anytime you say the opposite, when you save sodium, like aldosterone for example. Aldosterone is a mineralocorticoid that we talked about, and it's pro-sodium, meaning it save your sodium, it reabsorb your sodium, keep your sodium in the blood. So when you take back sodium to the blood, chloride will follow sodium, so you now have more sodium chloride in the blood. Water will follow, so you have sodium chloride and water that goes back to the blood, so and increase the blood volume and blood pressure. So natriuretic peptide is doing the opposite of aldosterone, and also the opposite of ADH. So natriuretic, natriuresis, sodium, losing sodium in the urine. So you lose sodium, you lose chloride, you lose water, you decrease the blood volume, lowering the blood pressure. There are two types, atrial natriuretic peptide and brain natriuretic peptide. Atrial natriuretic peptide is a peptide that's produced from the atrium when the atrium are stretched by the increased volume of the blood, which means the blood pressure is high. So this will stretch the atrium. The atrium will secrete the natriuretic peptide or the atrial natriuretic peptide, and this will get rid of sodium in the urine, followed by chloride and water to lower down the blood volume, and the blood pressure goes down. So this is a reflex. Brain natriuretic peptide is actually not secreted from the brain, it's actually secreted from the heart too. But the reason why they call it brain natriuretic peptide, because they discovered it in the brain of one of the study animals. I think it was a pig or a rabbit or something, I don't remember exactly. It was one of the study animals, and they found it in the brain. They studied it and they found that this is a peptide that has a natriuretic effect, so they call it the brain natriuretic peptide. Later on they found it that's been released from the heart of humans, but they didn't change the name. The better name will be ventricular natriuretic peptide, but it's just called BNP. They used to call it this name and they didn't change it. Thyroxine, the next one is thyroxine, secrete thymosin, and thymosin will promote or coordinate the immune system. Gonads, we talked about that. The gonads are testes and ovaries, and each one of those will secrete different secretions that we talked about. Adipose tissue is kind of interesting. The adipose tissue will secrete two things, leptin and resistin. Leptin, there's a lot of investigations and work on leptin right now, because they found out that this is a hormone that's produced by the adipose tissue and goes to the hypothalamus to suppress the appetite. So if you wanted to lose weight, you can augment leptin, and they are working on that. So far it was not very successful, but they are still working on it to produce the leptin that goes to the hypothalamus, suppress appetite, so it can be used as a tool or as a mean of reducing body weight. And they found that people who are obese, they don't have enough leptin, or they don't have enough sensitivity toward leptin. Resistin, on the other hand, will promote resistance to insulin. So remember, resistin that's produced by the adipose tissue will promote resistance to insulin. Calcitriol, this is that we talked about before, that's produced from the kidney, one of the hormones that's produced from the kidney, stimulate calcium and phosphate absorption from the digestive tract. And here is one more rule. We said that sodium is always followed by chloride, and this will be followed by water. Here is the second rule: calcium is always followed by phosphate. You absorb calcium, you automatically absorb phosphate. You don't absorb calcium, you don't absorb phosphate. They always, phosphate always follow calcium. Renin-angiotensin system. This is an important system that secreted, the renin is secreted from the kidney, and this is important. We need to understand it. Renin-angiotensin system. Renin is produced from the kidney as a response to increase blood going to the kidney. So when the kidney receives less blood, less oxygen coming to it via the blood, so the kidney will perceive it as the blood pressure goes down, and it will react to that by secreting renin. Renin will activate another hormone that's called angiotensinogen to angiotensin. And the rule of thumb is, when you see gen at the end of any word, know that this is the inactive form of something else. So angiotensinogen is the inactive form of angiotensin. You just remove the gen and you get the active form. So angiotensinogen is not active. When the renin secreted, angiotensinogen will be activated to angiotensin 1, to angiotensin 2, and angiotensin 2 will work on the blood pressure to increase it back to normal, because the kidney said that the blood pressure goes down. How did the kidney know that the blood pressure goes down? Because it started to receive less blood. So now the angiotensin 2 will increase the blood pressure by 4 different means. Number 1, it's going to stimulate the release of aldosterone. We mentioned before that aldosterone will cause sodium reabsorption. So when you reabsorb sodium, automatically reabsorb chloride. You have sodium chloride going back to the blood. This will be followed by water. You increase the volume of the water by fluid retention. You're increasing the blood pressure back to normal. This is 1. Plus, it stimulates the ADH secretion. ADH, antidiuretic hormone, the hormone that's against diuresis. So it will reabsorb water back, another step toward increasing, or toward the fluid retention, or increasing the volume of the blood by increasing the water reabsorption. So again, the rule is, when the blood volume increase, blood pressure increase. Is that it? No, there is stimulation of the thirst mechanism. So the angiotensin 2 will go to the hypothalamus, stimulate thirsty. When you feel thirsty, you are going to drink more water. The water go to the blood, increasing the volume of the blood, increasing the pressure. So far we increased the pressure back by 3 different means. The 4th one is coming actually from the name, angiotensin. Angio means blood vessel, tensin means tension. So this is the hormone that tends the blood vessel, meaning it constricts the blood vessels. And when you constrict the blood vessels, the blood will have more friction with the wall of the blood vessels, so that will increase the blood pressure. So this is a renin-angiotensin system. Since we're talking about this issue here, we're talking about renin, and we're talking about decreasing blood pressure, the other effect of the kidney, when the kidney receive less blood and less oxygen, besides secreting renin and increasing the blood pressure back to normal via these mechanisms that we talked about, it will also secrete erythropoietin, which is another hormone. And we mentioned that erythro means red, which means red blood cells. Poietin means poiesis, or manufacturing or making. So this will go to the bone marrow, stimulating the secretion of RBCs. What RBCs have to do with the blood pressure. First of all, more RBCs will make the blood more viscous, will increase the friction of the blood against the wall of the blood vessels, and that also will add another factor to increase the blood pressure back to normal. And since the blood pressure goes down, when you increase the red blood cells, it will carry more oxygen to the deprived tissues. So this is for the kidney function as an endocrine, as helping the endocrine system. We talked about the heart. We talked about the natriuretic peptides, and the natriuretic peptides basically oppose angiotensin 2. And we said angiotensin 2 work through 4 different ways to increase the blood pressure. So obviously natriuretic peptides will reduce the blood pressure, which is the opposite of angiotensin. The thymus will secrete thymosin, which help the development and maintenance of the normal immune defense. Thymosin is a hormone that's released from the thymus, and the name is similar. Thymosin. So it's the hormone secreted from the thymus to develop and maintain the immune system. Testes, again, you need to know specifically which cells produce testosterone, which cell produce hormones. So interstitial cells will secrete testosterone, and cystenticular cells will secrete inhibin. And you need to know specifically what cells secrete which hormone. The inhibin will also support the differentiation, physical maturation of the sperms, so it has some effect on the sperms. The ovaries secrete estrogen, and estrogen is an umbrella for all female hormones like estradiol, progesterone, and so on. So this is an umbrella for, when you say estrogen, you mean any estrogen. So this is female hormones in general, just like androgen. Androgen is not the same as testosterone. Androgen is an umbrella that means male hormones in general. Testosterone is one of the androgens. Dihydrotestosterone is another one of the androgen, and so on. So the ovaries will produce estrogen, mainly estradiol, one form of the estrogen. But after ovulation, the follicles that contain the ova will release the ova out, and the rest of the follicle will change and become corpus luteum, and corpus luteum will secrete estrogen and progestin, and progesterone specifically. And progestin means pro-gestation, before gestation. Gestation means pregnancy. So this is a hormone that prepare the body of the uterus specifically for conception or pregnancy. We talked about the adipose tissue. We talked about the leptin and resistin. The hormonal interaction, the hormones can do opposing actions, like we talked about right now, natriuretic peptides and angiotensin 2. They have antagonistic or opposing effect. Synergetic effect is like aldosterone and ADH, for example. Both of them are additive, and both of them increase blood pressure. Permissive is one hormone is necessary for the action of the other one. So you have to have, like example, renin. Renin is permissive for angiotensin. It activates angiotensin to angiotensin. Integrative effect mean the hormones produce different and complementary results. So they work on two different parts, on two different spots, like ADH or like vitamin D and parathyroid hormone. Vitamin D increase absorption of calcium. Vitamin D increase absorption of calcium from the digestive system. Parathyroid hormone, on the other hand, will work on the kidney and the bone to increase calcium. So both of them are increasing calcium, but they integrate with each other, and they end up increasing calcium from different parts of the body. Growth hormone, thyroid hormone, insulin, parathyroid, calcitriol, and reproductive hormones are all or important hormone for growth, and you need to remember this. Growth hormone, thyroid hormones, insulin, parathyroid hormone or parathyroid, calcitriol, and reproductive hormones. Growth hormone have different effects. If you're talking about children, it will promote or support the muscular and skeletal development. So the children will grow. The child will grow through the effect of growth hormone. They become taller, they become more muscular, they grow until they get to the adult level. This is in children. Or in adults, on the other hand, it have another action. In adults, we don't get any taller. The bone length will not increase anymore. Actually, later on in life, it starts to decrease for some other reason, which is the compression of the vertebrae and bending and other things. But anyway, the growth hormone in adults will have another effect, which is it increases the blood glucose concentration, just like glucagon. Actually, it will maintain the normal blood glucose concentration, tending to increase it back to normal basically, but it normalizes it. The other thing is it mobilizes lipid reserve. It takes the lipid away from the reserve and make it available for other tissues to use. Thyroid hormone is important for fetal development, as we mentioned before, and also the first year of life. If it is absent, thyroid hormone is, we said that thyroid hormone is important for metabolism. This is in adults and children. If you talk about the fetus or the infant, it's not only important for that, it's also important or more important for the maturity of the nervous system. So any fetus or infant who don't have enough thyroid hormone, their nervous system will not maturate, and it will cause mental retardation. They call it cretinism. Cretinism is decreased thyroid hormone in fetus or infant, which will result in mental retardation and other changes in the body. Actually, it will cause some sort of dwarfism. So the infant will be short. When he starts to grow, he will still be short, like dwarf. He will be mentally retarded as well. This is called cretinism, some sort of dwarfism that's caused by dwarfism plus mental retardation. This is cretin and caused by decreased secretion of the thyroid hormone or deficiency of thyroid hormone. How about right before puberty? T4 is actually needed for the normal skeletal growth. If it is not available during that time before puberty, the normal skeletal development will not continue. The teenager will stop at this point. It will not become taller. Insulin, we said it decreases the glucose level in the blood. How? By pushing glucose inside the cells. It pushes the glucose across the cell membrane to enter inside the cell, so it leaves the bloodstream, so its level in the bloodstream will decrease. This is how insulin decreases blood glucose. It also pushes amino acid together with the glucose so that the cells use both of them. We talked about parathyroid hormone and calcitriol. Both of them increase calcium level in the blood by different ways. They actually take parathyroid hormone specifically, take the calcium from the bone, so the bone can become weaker, but it's more important to have normal calcium level in the blood, more important than weak bone, and it's something temporary until you get more calcium through nutrition. Reproductive hormone, androgen males, estrogen females, this is an umbrella. Generally speaking, they stimulate the cell growth and differentiation, and they make the secondary sexual characters. So gender related, meaning in females they will have the secondary sexual characters. The primary sexual characters are the gonads, basically, the testes in males and the ovaries in females. The secondary is something that will show up during puberty, which is basically the configuration of the male and female, like the hair and the armpit and around the genitalia and the breast development and the fat deposition and all other things. The next is general adaptation syndrome. If you are exposed to stress, the response is called adaptation to the stress. So there is a syndrome that's called the general adaptation syndrome, and this occurs if the body is exposed to stress that continuously. So at the beginning, you will have an alarm phase, and then we start to resist, and then you are exhausted. So alarm phase, resistant phase, exhaustion phase. Alarm phase, this is the immediate response. So you are exposed to stress right now. The autonomic nervous system will respond by recruiting the energy for you to fight or fright. And the epinephrine will be the dominant hormone in this case. So if you are fighting for a few minutes or something, this is alarm phase. Autonomic nervous system, sympathetic specifically, will help you to fight, and it will give you the energy needed. It will mobilize the energy reserve. Glycogen, for example, will leave the reserve where it was stored. It's move and break down to glucose so that you can get the glucose, release the energy so that you can fight. But how long can you fight? 1 minute, 5 minutes, 10 minutes? Can you fight for hours? No, you will go to the next phase. So the alarm phase, which is the first phase, is basically sympathetic. If you remember the sympathetic, you know the alarm phase. Mental alertness will increase, so you'll be alert during the fight. Energy consumption, you're fighting, so you use a lot of energy. Mobilization of energy, you get the lipids and glycogen out of the store and change it to glucose, and you can burn it and get energy out of it. Circulation will start to change. Blood supply go to the skeletal muscles, of course, because you need to fight, you need to use your muscles. So divert the blood flow to the skeletal muscles, and at this point, of course, you don't need the blood to go to the skin, for example. What is it going to do in the skin? Nothing. You don't want it to go to the kidney. Why? Because this is not the time to make urine or to filter the blood and make urine, and you need to go to the bathroom, for example. Digestive organ, this is not the time. You are in emergency. You're fighting. This is not the time to send the blood to the digestive organ to digest and absorb and form the excretions and so on. This is not the right time. So this is the right time to recruit all your blood and energy to the skeletal muscle and the brain so you can fight. So the digestion will be reduced, the activity. This is not the time to digest. This is not the time to make urine. You will be sweating, of course. If imagine you're fighting, you'll be sweating. Blood pressure, of course, goes up. Heart rate, of course, goes up. Respiration goes up. Respiratory rate, instead of breathing in a normal pace, you're going to increase your respiration. What if the fight is not a couple of minutes? What if it's a couple of hours? If that's the case, your second card is you cannot use epinephrine anymore, because the epinephrine is too drastic. It take all your energy and blood and divert it away. So if you stayed like that for some time, you are going to break down your body. But if that's the case, now the hormone is glucocorticoid. So you can actually resist for a couple of hours, and you still get some energy. You still get your energy from glycogen will be exhausted. You get all your glycogen from liver and muscle, and you start to get lipids and so on. So you can actually resist for a couple of hours, but it will not extend more than that. What happened during that? You start, the glycogen is gone during the alarming phase, or the alarm phase. So you start to count more on lipids and proteins reserve. You conserve glucose for neural tissues. You don't use it all for the fight because you are going to break down your nervous system. Blood glucose start to increase. You keep your salt water for yourself to keep your blood pressure keep it, not increase it, keep it because you're resistant. If that prolonged for more time, the homeostasis regulation will break down. You cannot persist. You cannot fight for 10-15 hours. Your system will break down. You cannot take it more than that. So the homeostatic regulation will break down and the organs start to fail, one or the other. Maybe the heart, maybe the brain, maybe the kidney, especially the kidney or anything else can break down. This is the last phase, which is the exhaustion, and you start to have the mineral imbalance, sodium, chloride, potassium, and minerals and other things start to have imbalance of those. Hormones and behavior. The hormones can actually not only do the physical part, but it can actually affect the intellectual capabilities, like memory, learning, emotions, and so on. The behavior change when the endocrine glands secrete or more or less. Aging, as we mentioned before, everything relates. And returning to the hormonal change, like example, androgen will make the emotional status or states will be more aggressive, and that's why males are a little bit more aggressive than females because of the androgen. And there are a lot of complicated effects on the intellectual functions. Aging in general, everything deteriorates, so the concentration of growth hormone will deteriorate. The body does not grow, actually it starts to lose the muscles and lose the body part, muscles and fat and so on. Reproductive hormone goes down and so on. Functions in general deteriorate and so on. There are some disorders. Then disorders can be primary, and primary means within the organ itself, like metabolic factors can make it. Physical damage, you have an accident that broke down the organ, pituitary gland, the thyroid gland, or anything else, or you might have a congenital problem, you didn't develop full thyroid gland, didn't develop full testes or ovaries or parathyroid or anything else, congenital anomalies. But primary disorders means the organ itself has a problem. So the thyroid gland itself having a problem, and that's why it does not secrete thyroid hormone. On the other hand, the secondary disorders is not because of the organ. It is either coming from another organ or the target tissue. Meaning, why the thyroid is not secreting thyroid hormone? Because the pituitary didn't send the TSH, or the hypothalamus didn't send the TRH, or both of them. Or the thyroid gland is still okay, secrete thyroid, and the thyroid is not effective because the organs are not responding or the tissues are not responding. So if you have a problem with the hormonal secretion, ask yourself, is the problem with the gland that secrete this hormone? Example, thyroid hormone is not secreted in good amount from the thyroid gland. Is the reason from thyroid gland itself? That will be primary. If the thyroid gland is fine but not secreting, even though there's nothing wrong with the thyroid, it's coming from above or under. Important concepts, these are very important to know. I put the names here, but you need to know all of them. It's very important. Expect to see it. We went through a couple of them, but you need to know them anyway. Gigantism, for example, this is the body will become giant. This is a person who is huge, and this is due to increased growth hormone in infancy or before puberty. What if the growth hormone increased after puberty? It will not become giant, but it will cause acromegaly. Acro means dependent parts or the periphery. So megaly means increase size. So the periphery will increase size. So meaning the nose will become larger. The person will not become taller or increase the length of the bone. But some of the body parts can still grow just a little bit. Not the entire body. A little bit of the body organ or body parts. Like the nose will grow, the forehead can still grow a little bit, the mandible can grow, the fingers can grow, the foot can grow, and Abraham Lincoln is an example of that. If you look at Abraham Lincoln's picture, you will see what I'm talking about. You will see that his forehead is projecting, it is a little bit bigger, mandible is a little bit bigger, cheeks are a little bit bigger, his fingers, his foot, and so on. So actually Abraham Lincoln had acromegaly because he had a tumor in the pituitary gland after puberty. If it was before puberty, this is gigantism. Giantism, and giantism is a symmetrical growth. Everything grow. So a person will become giant. Everything, not just nose or hand or forehead, just like the acromegaly. Now, what if before puberty this person or this kid didn't have enough growth hormone? So it's the opposite. He will become dwarf. So dwarfism means dwarf. He will become a small size person. The next thing is vitamin D deficiency. What if a person having a vitamin D deficiency? The question will be vitamin D deficiency in kids or adults? If it is in kids, rickets. The bone will become weak and it will start to bend. This is called rickets. So rickets is vitamin D deficiency in children due to either malnutrition, due to no enough exposure to sun. So if the kids are having a little bit of exposure to sun, enough to enable them to make vitamin D, the body actually needs the ultraviolet in reasonable amount. The ultraviolet radiation come from the sun that activate vitamin D. If they are not exposed, like they are, they stay home the whole day long, every day, they don't see the sun or they don't see it enough, they will not be exposed to enough ultraviolet radiation, and ultraviolet radiation will work on the skin, normally work on the skin to activate and work on vitamin D so that the skin can make vitamin D and activate it. So if they are deprived, they will not make vitamin D, and vitamin D is important for absorption of calcium from the digestive system. So they don't have enough calcium, their bone will not be calcified enough, and calcification make the bone hard. So if it's not calcified, it will become a little bit soft, start to bend. This is rickets. What if this is an adult or after puberty and he has vitamin D deficiency? This is something else, kind of similar to rickets, but in adult, and this is called osteomalacia. Osteoporosis, on the other hand, have nothing to do with vitamin D. This is a condition that occur more in females after menopause, and it is actually a hormonal problem. Estrogen is important for making the bone strong. It's important for calcification of the bone. After menopause, estrogen goes down and the effect of estrogen in the bone decrease, and the bone will not become calcified enough. It will become eroded and weak and porous, and this is where the name came from, osteoporosis. Osteo means bone, porosis means porous. So it starts to become porous, looks like kind of a spongy, or contain cavities and weak. So, and this is when we hear about elderly people, especially elderly ladies, grandma or something, that she fell down in the bathroom or somewhere else, just a little bit of a fall down, or just a little bit of hitting something that's minor, that doesn't do anything in younger people, and she got fracture of the pelvis or fracture of the pelvic bone, because the bone at this point will become very weak. And this is the reason why some people choose to take estrogen replacement therapy after menopause, to make their bone stronger and to look a little bit younger. You don't look older and so on. But there are some other effects related to increasing the incidence of some cancers and some blood problems, so it's kind of complicated. Diabetes mellitus is deficiency of, generally speaking, it's increased blood sugar in general, hyperglycemia. There are two types of diabetes mellitus. There is type 1 and type 2. Type 1 is due to lack of insulin, and this is usually in children. Type 2 is they have insulin, but the tissues are not responding to. So if that's the case, glucose will not leave the blood and go to the cells. So it will stay in the blood, causing hyperglycemia. And being hyperglycemia, it will be secreted in the urine, followed by water. And this is why people with diabetes mellitus, they have the polyuria, polydipsia polyuria. Polydipsia means they drink a lot, they go to the bathroom a lot. Diabetes insipidus have nothing to do with diabetes mellitus. The only thing in common is the word, the first part, which is diabetes. And diabetes means increased water, and increased water that goes to the urine. Insipidus, this is the lack of ADH. So in both cases, in both diabetes, the body will secrete more water in the urine. So polyuria in both cases. Polyuria means a lot of urine, or frequency, increased frequency of urine. They wake up in the middle of the night 4, 5, 6 times, go to the bathroom because they have a lot of urine. Why? Because they secrete a lot of water. Why? It depends. If it's a diabetes mellitus, it's because of the high blood glucose that's secreted and take water with it when it go in the urine. Diabetes insipidus, you don't have enough ADH, and ADH normal function is antidiuretic, meaning it return the water back to the blood. If it is deficient, it will not return the water back to the blood. More water lost in the urine, more frequent urine. And this is diabetes insipidus. And again, this last slide is important. Each one of these concepts is important to know as an application to this chapter, which is the endocrine, and this will be the end of chapter 18, the endocrine system.